Here you go.
You're a little camera shy?
Yeah, it's like the podcast. Okay, good.
Oh, okay,
I don't need who cares what I'm wearing?
I don't. If you want, we can set it up to where you're over there and I'm the only person on camera.
Oh,
it's
right.
completely up to you. This is your episode, Michalyn. I so appreciate you coming on and giving me a chance and an opportunity to interview. I know you're busy.
Yeah, I was like, oh, okay, this is different.
Yeah, I mean, you're very interesting, and you're one of our teachers. And I've just had this thing going on for probably 4 years now. Mm-hmm. And during school, I kind of took like a little 2-year break just to focus on school and doing what I need to be doing essentially. But now that I'm done with school and
mm-hmm.
Passed the test that I needed to pass, I'm kind of like, I met some cool classmates. I kind of want to get them on here.
Good.
Some of you teachers, if you guys are free and interested in doing this, but I have 136 episodes of this, of just people from all over the county. Kind of like the message I sent you, and I'm ready to. I have a bunch of questions for you, and I don't want to take too much of your evening, so I'm ready to get started.
All right. Yeah.
Okay, so you. And before I start with the detailed questions, because I definitely want to talk about some of the hospital stuff, if that's okay with you. Some background would be nice. You went to Cuesta College and graduated from that nursing program?
Yeah.
Okay. And then what made you want to become a teacher there? You like to teach, huh?
I loved to teach. I used to write teaching venues for the people I hired in the department I was running. So it made me feel, happy to see them grow and then thrive. So that, yeah. I like to make people feel happy with what they're doing.
Yeah.
Yeah.
Yeah. And you made us all happy.
Yeah.
You really did.
And I can be pretty strong and willed and make you be a little bossy, but we all get there.
And you're a pretty good teacher too. There was a few lectures where I was like, okay, wait, I need to go home and just get into the zone and review all of this. But I'd say a fair amount of the most of the time you especially when we started talking about the specifics of the hearts and heart failure stuff, heart attacks, and the different sort of protocols and whatnot, I was like, what you're talking about, you know what I mean? You're good at teaching. I like it, and you go off on kind of some tangents sometimes, but it makes sense because you're talking about detailed specific incidences.
Yeah,
you know what I mean?
They'll line up eventually.
Yeah.
So.
How long have you been teaching at Cuesta?
6 years.
Okay. Mm-hmm. So not
this will be my 6th year.
Not an insane amount of time,
no.
But a
so
fair amount.
when you came along with your class, I'd only been there 3 years.
Cool.
Yeah.
Cool.
So, yeah. But it's good. I like it.
And then
it's nice to grow people that are going to do what you loved.
And you you're a good nerd. You're a patient advocate.
Yeah.
You are a patient advocate for sure.
It's always about the patient and the story behind the patient.
Yeah.
Yeah.
Because you are genuinely caring and you want to help see someone do better. And when there's a bad nurse in terms of not doing when you teach, you're giving us information on what to do. You want all of us to be like that. You know what I mean? I guess good nursing, you know, because you genuinely care about the people you're taking care of.
Mm-hmm. I do.
Yeah.
Yeah. And you got to really kind of try and know the patient.
Mm-hmm.
And I like that part. I like to know their history and their background and what they did besides wear a hospital gown.
Yeah. Yeah.
You got to take that hospital gown off and look at the person.
Yeah.
Yeah.
And then how long have you been a registered nurse for?
This will be my 30th year.
Okay.
Yay.
Cool. Are you having a celebratory?
I was 30 when I started and I'm 60 now. It's oh
nice.
My gosh. It's a whole different twist.
Yeah. And that leads me into I'm pretty sure it was fourth semester. It might have been third semester. I forget, but I remember like on Canvas when you click on the profiles and you go into like the front web page, like it shows the bio or whatever, and you talk about, you know, yourself, where you live, how long you've been doing nursing, and it was saying your bio is saying about yourself that you helped get implemented the non-STEMI in sepsis protocol. French.
Yeah, we wanted to be the STEMI receiving center.
How does that work?
And so you actually apply with the state, and the state reviewers come, and you have to have protocols on how you're going to work with the response system. And so you have to be part of EMS and how you're going to work with the other hospitals. So we had to have the other hospitals on board with how we were going to work together. We met it with the ER doctors, the cardiologists, and the EMS system multiple times to kind of create a path that was better for the community, because then they didn't stop. Each time I did something that took extra time from my regular job, it always had a patient. So that patient, her name was and had been triaged at another facility, and unfortunately she stayed there so long, and it took so long for her to get the proper care that she actually turned into what we call a cardiac cripple, and she never survived much of a life after that. So we were like, we got to change this. And it wasn't the other hospital's fault, it was just the way the system was. You know, they stop and they pause and they triage, and then they do workup on people. So it was kind of exciting to see, like, how could we integrate it, because it was a couple of years prior to the state guidelines coming out. So we didn't have the recipe that the state was going to make us do. But by the time we were done, the state guidelines came out like 6 months later.
With your project?
And had been passed and acknowledged as the receiving center. So that makes it so that the emergency response system doesn't have to stop at other hospitals when they for sure have somebody that has a STEMI going on. So if they think they're going to have a heart attack that's, you know, going to kind of cripple them for life, they can just pass the other facilities, saving lots of time.
So you're saying the patient you guys had that made you kind of implement all of this and wants to get like a protocol or like a plan to follow, you said too much time had kind of passed by.
Yes.
In terms of their heart tissue being deprived of oxygen, and then it's just like
way too
necrotizing.
Long. Yep. By the time we got her, she didn't have any motion or movement back, even though we did open up the vessels. It had just been too long. So that was it was very sad. And it wasn't just me. It was like very led by one of our leading cardiologists at the time. And him and I actually also later had a bad incident with a person having a femoral access. And that made us be prompted to try and become the first to treat STEMIs with a radial access. Prior to it being something that we were told by other, I think CMS now actually says to do that. But at the time, it was something we chose to do based off of another patient who had a very bad outcome from that. So, yeah, he was actually a very... He had his opinions, but he was a very strong leader, and he actually could keep us together as a group, and that kind of helped make it work, you know. And he knew when somebody had too much. Yeah. So I always appreciated that. I saw him at a restaurant recently.
Oh, nice.
It was really nice, And he was like, "Oh, wow, you're looking great," and I'm like, "Yeah, you do." So it's kind of, we both parted other ways, but it's nice to see that things we worked really hard on probably made a difference. Yeah.
So when someone's having a heart attack, where was all the time going when like when you're saying, hey, too much time had passed, too much heart tissue had died, we need a system, a plan to follow when someone is having a heart attack? Like, can you give an example? Like is ambulance going to the wrong hospital, or are they waiting in the emergency too long? Like, where's all the time going?
Well, sometimes it's the family drives them to the hospital, and then when they get there, getting in the door and getting through the triage process, and some people don't articulate things well, and she was female, she might not have called it chest pain. So in all of that, at the other facility, you know, we never caused blame, but it surely was over an hour and a half. It was hours before she decided that she was having a heart attack, and then they called us. Then there's another ambulance that has to come pick that person up and then transfer them one more time. So, you know, in and all of that, you're 2 hours plus. That could have been avoided if the patient, you know, had been brought to the correct facility in the first place. But sometimes it's always hard to do the right thing, because I'm not sure if her husband drove her to that facility. Yeah, but long story short, we remembered that patient for a very long time.
Why can't you get treatment at a different hospital?
They don't have cath labs.
Oh, and you need a cath lab
to do the cath lab to fix
PCI, percutaneous intervention.
Yes.
Okay.
So you need a cath lab to fix the problem.
Okay.
You can give them drugs, but that's not the gold standard.
Mm-hmm.
They're not going to have the same outcome. So.
And you're a cath lab nurse.
Yeah.
You were for most of your career?
For quite a few years. I went into that kind of on default.
Yeah.
That was a different story. But
were you ever like med surg, like on the floor?
I worked on
patients?
med surg, DOU. I actually loved med surg DOU because there you could do a lot of patient teaching. I really appreciated that. I always am gung ho for people to start there.
Yeah.
Yeah.
Yeah. No. Yeah.
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 Because it helps you put it all together and recognize what a patient that has the symptomology really does look like.
Mm-hmm.
Yeah. And especially when they don't tell you.
Yeah.
And you're kind of trying to piece it together.
Yeah.
That you become a better detective. Yeah. So that's a good thing.
When someone's having a heart attack, like the treatment is doing the percutaneous intervention in the cath lab.
Yes, as quick as possible. Less than 90 minutes.
And that's crazy that... Am I allowed to say hospital names or no?
I don't know. That's why
okay, I'll take out all the hospital names.
Yeah.
I'll just bleep it out.
Okay.
I can't... doesn't have a cath lab.
It does. It has a beautiful cath lab. Yeah.
So
we all
if you're
worked
having
there
a heart
for
attack,
5 years. They aren't allowed. So as a STEMI receiving center, we're the center to hold the equipment for everything. So they're allowed to have emergency equipment, which is a very, very, very bare bones. It would be like saying in your cupboard you have a salt, pepper, 1 can of beans, and a loaf of bread. Versus like a full stocked shelf, right? And everybody has a different size vessel and a different. So they have pretty much nothing if. Because that's just the rules, that guidelines that the state makes with it. So all of the equipment's over at the other, and it would be kind of criminal to treat them there. But they do have it, except for now things modernize so quickly. It's an antique.
Yeah.
But maybe Adventist Health will put money into it, or go down another line that's for the stroke center or something. So, because they do have a beautiful. So the CVICU, we were all there, and that we were part of the planning for creating the CVICU. I remember talking about where the rooms would be and how we'd come up the elevator and how we'd bring our patients, and well.
CV, like cardiovascular.
It's
okay.
So it's They have a cardiovascular ICU.
Gotcha.
And then they have the other ICU. And the cardiovascular ICU came up from the middle of the cath lab in the OR. So when you went out our door, you went up a separate elevator that didn't go to the outside, so we didn't have to go through halls or anything.
Yeah.
It was lovely. It was really nice.
Yeah.
They did a really good job.
Yeah. What is it, so you have like, was it you want to get percutaneous intervention, is it within 60 minutes?
90 30s would be like perfect. Okay. But 90 minutes before we could truly say you're gonna have some effect from this. Yeah.
And
I mean, everybody's fully different,
yeah.
But that's what the American Heart puts out. That's what the studies have showed. So we strive to hit 30 if we can. And when we first started, could give us a patient in 27 minutes from the time they hit their door to the time they hit our door. And then that still gave us almost an hour, right, to fix the problem. So they were very impressive.
Do the patients know to come to you guys, or are they just going to the nearest hospital?
Not always, but the EMS all does. So the EMS was part of the protocol. And
that's done on like the radios and stuff.
And they communicate with the physicians and yes. And so they follow the protocol that was written saying if you see this ST elevation or a new left bundle, well, you don't know if it's new or not because it's the only first time you saw it. But they bring them. Fortunately, sometimes paced rhythms look like a new left bundle. But the cardiologists now have view it. I'm so old. When we first started out, we didn't have full view. So they unfortunately would have to drive in and be like, it's a paced rhythm.
Gotcha. Okay.
Yeah. So, unfortunately.
Yeah.
But that's just, healthcare has just gotten so good in the last 15 years.
And it's like, I'm guessing in even 20 years, healthcare will look back right now and be like, oh, that was barbaric what they were doing, right?
Yeah, it will.
Like, as medication continues to advance and there's just more and more technology and like science and research being implemented into everything.
Yeah, it will. It'll keep going on and on. It's good. It's good. Yeah. You excited about your new?
For
career?
Sure.
Yeah.
Like 100%. I'm very excited to get into a process in terms of I guess and sorry I'm sweating so much. I sweat a lot.
It's okay.
But I'm ready to get into work and just continuing to learn. And the thing is, I know I'm not gonna be good at first, but I'm naturally I really like to become good at most things that I do, and that's something that I want to get really good at doing. You know what I mean? Just talking to people, memory, knowing where I am, the setting, who's a priority at this given time, who's not a priority at this given time, being able to I want to get good at everything. You know what I mean? So I'm super excited, and I'm ready to dedicate a good chunk of time to doing nursing for sure, 100%. I'm just gonna be eating healthy, gym, sleep. Honestly, probably not gonna be drinking or anything. I might cut drinking out of my life for a while. I just want to focus and
keep a clear head.
Yeah, keep a clear head.
Good.
Yeah, I'm excited.
That's super exciting.
I'm beyond excited. And I was in school for probably I'd say a little longer than the average person, because I was at Cuesta for a couple years, just doing English, math classes, working part-time, didn't really know what I wanted. And then I kind of figured out and I think it was 2018, I started doing the prerequisites.
Oh, okay.
But I didn't really know time frame. It all worked out, but just time frames and working. Like I just kind of, I seriously, I just went at my own pace, and then had to like retake physiology. So I had to retake a class and get an A in it. And so that kind of like added on another year. And then first year I applied, didn't get in. Second year got in. So now it's 2024 and I've been at Cuesta since like 2016. So it's
a good start.
It'll be nice to not be in school for like pretty much the first time in my entire life. Seriously, I
can't remember when you weren't.
I can't remember when I wasn't and had something due, and I'm ready to I guess in a sense grow up a little bit. Yeah.
That's cool. That's
I'm
good.
I'm excited for sure,
Yeah.
and I'll be working in SLO and I'm down the street.
Yeah,
you know what I mean?
the best.
I might be riding my bike there
Yeah.
at 5 a.m.
Yeah, perfect.
Or
Yeah.
in the evening because I'll be doing night shifts.
Eventually, yeah.
Yeah.
Well, that'll be great to see you there.
Yeah. You're not working a lot there.
I quit that job in June.
You're done?
Mm-hmm.
No. Wait, why'd you quit?
I was like, oh no, I'll just do teaching.
For real?
Yeah.
Was it? Okay.
It was kind of nice. It kind of was like, oh yeah.
So you're retired from one of your jobs now.
Mm-hmm.
You're not going to start up again.
Nope.
Wow. Okay.
Yeah.
Congratulations.
Yeah.
Congratulations.
I was like, yay! I love it. It's nice.
Did you guys have a dinner at your house to celebrate?
No,
or anything?
you should have. But I was like,
You're just like, yeah.
Yeah. I'd been there done it so long.
Yeah.
And yeah. Eventually, maybe when I'm not teaching too, but teaching's been full time.
And especially your position at Cuesta.
Yeah.
Like you do the labs.
Yeah. They're very
and
busy.
And that's what, 4 hours?
Yeah.
Yeah.
They're long.
Yeah. And you do a bunch of the simulation stuff. And you're a clinical instructor, plus your lectures are in there too.
Yeah. It's a little it's kind of a mixed up pot.
Yeah. Yeah.
But that's all good thing.
Yeah.
Yeah. We love it. So.
Will we see you at the hospital?
Oh yeah.
Really?
Monday, Tuesday.
Okay, cool.
Yeah, you can't get rid of me.
No, I want to see you.
Yeah, it's always good.
I'm waiting for the day where I'm in the uniform and you're there and eating something. And I'm like, yo, do you remember me?
Yeah, I do. And then someday I'll ask you, can you mentor this student who's
so down.
Shaking?
I'm so down. I like teaching.
Yeah.
I like teaching and yeah, but I need to get good first. You know?
Yeah.
Yeah.
I give you time.
Cool.
I've been kind to them.
Yeah.
If they switch to days too, I give them more time.
Yeah.
It takes a while to feel like you have your own groove, and that's important because it's all about patient safety.
Mm-hmm.
Yeah. Gotta keep them safe.
How did you? So you were an assistant nurse manager.
Well, I was a nursing supervisor when I was in the cath lab.
What's that mean?
So we had a director, and the director was a tech, and then I was the nursing supervisor. And we just worked collaboratively because we have a lot of techs in the cath lab. And he couldn't be over, writing the STEMI protocol. He couldn't be over policies, things like that, because it's nurse-driven. So we had to work together. And then he did all the parts about ordering all of the equipment and what the doctors liked. So we had a very good system. It worked out well.
How, when did you want to get off the floor and be in a supervisory position or assistant nurse manager position?
It kind of just evolved.
Okay.
Yeah. It wasn't something I'd planned. It just kind of evolved that way, and yeah.
Did they approach you, or did you apply for the position?
No, it was more of an approach.
Okay.
Because the other person had been left kind of abruptly.
Gotcha.
Yeah, and we'd all worked together for a very long time. It wasn't like I just jumped into something I hadn't done. So that was okay. Yeah, But it was like, oh, well, you want to try it out? And then after you try it out, you're kind of wearing the pants and doing the job and being the boss. And that's okay. I actually, that's where I learned that I liked teaching, because then we had to hire new people. And that was good because the new people had to learn. Yeah. And I wrote things up to help them stay safe and feel like they knew what we were doing. So, yeah, I liked that.
What made you want to do Cath Lab?
Oh, that was by default. Like,
they put you there?
No. So let's see, what year was that? 2000. In 2000, I had cancer, and I did. And two of the people I had sat with, you sit in these big, giant lazy boy chairs when you have your chemo. And the other two people that always sat next to me were actually patients in the hospital, and they weren't doing well. It was kind of like their cancer had come back, and they were having really bad outcomes. And it just was, I was so upset. So I went outside to get fresh air, and there was this tech director. He's like, "What's wrong with you?" And I was telling him, my story. And he's like, "Oh, you just need to come and work with us." And that's how I started the job. And so I went and worked with them.
I hope you're cured now.
Yeah.
Okay.
Yeah. All right, 20 years. Yeah. No.
Cool.
But it's just kind of weird.
Yeah.
It was I guess God wanted me to be there, because we just met up in the parking lot, and then in a couple of weeks I had a new job at a new facility.
And you, what made you agree so willingly? If someone offered somebody a job that, you're already working somewhere, you might like that job, why, what made you leave so...
Oh, I knew I didn't fit anymore right there.
You were open to it?
I was open to
That's
it.
Funny.
It felt real uncomfortable.
Okay.
When I came back, there had been multiple people I had treated, but these two were people I had sat by for 12 weeks plus, and it didn't feel good at all. So I was like, I need a change.
Yeah.
So, and I'm always willing to take a little risk. It was a safe risk. It wasn't it was a very safe risk.
You weren't moving to another state? Or
no, it was a safe risk. And
cool.
Yeah, I've always been kind of like that. Let's try it.
Yeah.
So it was good. So that's how I got there. I never thought I'd be a procedural nurse or ever be a supervisor. That wasn't my dig when I was in nursing school.
Yeah.
But it's okay.
You have a master's degree?
Uh-huh.
That's cool.
So cool. After the Cath Lab, for many years, I kind of just got a little tired of call, and I was like, okay, what am I going to do when I'm 50? And I was 47, and I actually thought I wanted to start teaching, but I called Marcia, who was the director, and she said, oh, you can't go from the Cath Lab to Cuesta. You can't be in a specialty. The Board of Registered Nursing wants you to be on med surge.
Gotcha.
So I quit the Cath Lab, and I went back to being assistant director on tele, because that's kind of where we grow our students. Mm-hmm. And I went back to school at the same time. And then that's how that all happened.
Cool. It takes, so you, after Cuesta, you had an associate's degree. Mm-hmm. Where did you go to get your bachelor's?
I did it all online.
Bachelor's online?
I did the bachelor's and I did the master's online. And that was pre-COVID. It wasn't something everybody thought was so great back then, but it was fine. I didn't feel like I got lesser of an education. My daughter has a fancy master's.
Okay.
In-person classes.
Okay.
She does have very amazing teachers and has had, but I didn't want to move, so it's okay. I recommend that to you if that's what you want to do later. They have a wonderful reimbursement process at. So.
I think Eli may have convinced me to get a master's. I think I'm gonna not anytime soon,
Right.
but within the next like 5 years.
Yes.
Yeah. And I was actually, before this, I was actually with Eli.
Oh, good.
They're Eli, Audrey, Ariana, and a couple of Eli's friends. They're playing trivia right now down the street. So I was like, all right,
good.
like you guys are playing at 6, so I'll pop by for a little bit, but I gotta come here out there.
Oh, that's cute.
No, I didn't tell them I was interviewing you because I wanted the interview to like happen first.
Oh, okay.
But Eli came on this.
Oh, that's good.
Yeah,
Good.
and Eli told me, about his career and working at Twin Cities and whatnot, and his background and stuff. So
yeah,
I appreciate when you guys give me a chance and an opportunity to come on and let me interview you.
It's nice to.
Yeah, I mean, because at the end of the day, I'm also growing this as a platform,
Mm-hmm.
for whatever I need to be doing in my future.
Uh-huh.
Like I'm kind of stoked that I have a podcast and interview people, because from you guys I'm acquiring some of your knowledge and whatnot.
Uh-huh.
So
Of course you are.
and like if I think one day eventually it'd be nice to kind of go into some sort of like policy changing thing, and I feel like having like a platform like this in your background is like
it would be great.
a good foundation, like.
And all of ours were the sepsis, the radial, and the STEMI that we all worked really hard on. Those all were related to one patient. And we always all talked about that patient and how this is going to make the difference. Because it helped us focus our energy and recognize that it's not just about being something, right?
Yeah.
It's about making a difference for those people.
For sure.
Yeah. So, yeah, we did. We always kept the person the center. So it helped a lot.
Isn't that crazy when somebody's having a heart attack? You guys go through the radial artery into the heart, and that's all done using like a guide wire, and there's a camera on the ends, right? Or no camera?
No, not really. No. Mm-mm. They just use contrast, and the contrast shows the imaging from the X-ray that they're taking at the same time, so we can see it. So there is a system that does have capacity to see intra-arterial ultrasound, and we can see like luminations of the artery. And that's a whole separate catheter that goes in.
How do you even get a catheter into that spot?
Yeah, they have a lot
Could
of
you
finesse.
do it?
No.
Okay.
No.
How do you do it?
The physicians, I'm sure
they went to school for 8 years.
They went to school. Well, they go to school and then they specialize after, and then they probably have a lot of guidance and proctoring.
Yeah.
And the utilization of each wire. Some wires are stiffer than other wires. Some actually have a curvature more than others. So, and that's all related to what we've seen in the beginning. We start pulling things related to what we think will fit. It's kind of like a pair of pants. Like, that you look like a 34. Right?
Yeah.
And, it's kind of the same thought.
Yeah.
Yeah. And then it'll advance a little better. But yes. And, some are better than others.
Yeah. Yeah.
It's kind of like driving a car. Some drive a car a little smoother than other people. It's kind of the same thing.
Is part of the protocol the medications you guys give upon arrival? Is that part of the protocol?
Starts the whole.
Okay.
Yes, and it starts with the EMS, and then it carries to the ER people, and then those people carry to the cath lab people. So the whole protocol kind of has a stack. And then that's why we had to work with the EMS, and we had to work with all the ERs in the community. So that they knew what we were doing, and they all followed that, and we worked together. If it didn't work well, if our time was going down, then we would change.
It's the main meds. It's aspirin, morphine.
That's if you need it. But for sure, you're going to give them
an antiplatelet.
Yes. So you're going to give them an aspirin, and then if we know we're going somewhere, we're usually going to load them with heparin. Yeah, 40 to 50 units per kilogram, which everybody's close to 100 kilos, so it's like 5,000. And so they get the heparin, they get the aspirin, then we actually give them more antiplatelets, right? So
and that's where like the clopidogrel and the P2Y12 stuff.
That is a P2. Is a P2Y12 like Brilinta, clopidogrel, Brilinta's tritegalor, and then what is it? Effient. Then we have 3 that we would utilize more. But we also give them other things that inhibit clotting factors. So.
And then if they're going home on the ACE inhibitor, if their ejection fraction is less than 40%, and
everybody gets a beta
more
blocker.
aspirin and stuff.
Yeah, and everybody gets a beta blocker.
Beta blocker, yes.
I'll get a beta blocker.
Calcium channel blocker?
No, not necessarily, but a beta blocker for sure.
Okay.
And then, because we want to keep the beta cells down, we don't want them too active. We want to kind of let the muscle slow down and heal, right? So everybody gets that, and everybody gets a statin because if you have plaque, you have your cholesterol, no matter what the number is too high. You won the prize.
Next month, I'm going to review all of that stuff again.
Yeah, and they'll give you classes.
It's such good information. It's such good information.
Yeah.
I never thought I'd be into the heart stuff, but I like it.
I like it too.
I like it.
It's pretty cool.
Yeah.
It's the dynamics of all of it's really neat. And to help your patients have a better outcome, they come in and they're so scared and they felt like they tasted death. And then when they leave, they feel wonderful. And, now you can give them medications to give them a very long life. And that's like really exciting.
Nitroglycerin was one of the meds too. Upon arrival.
Yeah, we give nitroglycerin if they can take it.
Okay.
But sometimes their blood pressure is not good.
Too low.
Yeah. So it's not something you're gonna do.
What else is part of this protocol for the heart attacks? We kind of talked about like the medications, where they're going, cath lab stuff. Like
that they see the doctor in so many days, that they have a follow-up with the cardiologist. Many of them don't have a cardiologist when they come in.
They need one.
Yeah, so we'll make
days.
the appointment. Yeah, call, make the appointment, make sure they have that. Then they also get rehab, and that starts within about a month. They'll get 6 good weeks. And in rehab, they do a lot of the teaching. Because you only can take in so much in the 2-3 days you're there.
Yeah.
But they do a lot of teaching, a lot of reviewing of the medications and the blood pressure and exercise tolerance and diet. So the long haul is the rehab that they get, which is patients really like it.
Yeah.
Yeah. Makes them feel like enabled because they're scared to exercise afterwards.
Yeah.
Because they maybe were taking a walk or something. Yeah.
Yeah.
So.
What is let's talk about the sepsis protocol a little bit. Like, what does that even mean?
Oh, well, many hospitals had a sepsis protocol and we didn't have one. So one of the intensivists knew I was doing my master's and knew I had to do some kind of capstone project. So he was like, I want you, and I sat on 2 committees with them. And we sat on critical care together and pharmacology together. So he was always bugging me. So we decided that was going to be what we did. And again, it was the lady's name. It was about a patient that came in and walked in with her daughter and had a urinary tract infection and was evolving sepsis. But we didn't quite catch that she was evolving sepsis when we should have. She had signs and symptoms, but she was talkative, cheerful, and she didn't last but 24 hours. Whoa. So it was very sad. It was very sad for the nurse caring for her and the whole pathway. We all were frustrated, right? Like that we didn't do things soon enough.
Yeah.
That we should have for her. Not that we weren't trying, but by having a protocol, it would have like implemented more in the ER. And then it's when they get those things within the first hour in the ER, and we kind of hit them hard and fast, that we can maybe turn them around. Because you have about a 4-hour window.
For sepsis?
Yeah.
Like in the, what phase would you say? Like initial, compensatory, or there's another one, then there's like a few phases of sepsis, right?
Yeah, it's before they can turn into some form of like severe sepsis, and that's always before you've
refractory phase.
Before you've defined what it really was.
Okay.
Like I haven't gotten my urine sample back. I haven't gotten anything back. It's really actually before that, and the body's in this hyperbolic state where it doesn't know what's going on, and so it starts separating fluids in wrong spaces, and the person really doesn't have volume inside their blood system. And so it's in that window, you have this 4 hours. And if you get to the other side, especially for an elderly person, it's just too far. It's too much. Sometimes they just can't rebound. Even though you think they should be able to, they can't. So that's always really hard.
The main things they need is fluids and antibiotics, right?
Fluids and antibiotics to try and reverse it. So within that 4-hour window, we should be reassessing if they do need some kind of pressor to turn them around, because sometimes the older people can't get a lot of fluid. Pressors aren't always good themselves, because they cause ischemia to your distal extremities, right? They press down everywhere, and when you have a narrower vessel at the distal and you're old and it's
dangerous.
It's
all dangerous.
It's all very dangerous. It's very sad. But so we wanted to start a protocol, so we did, and we worked with the ER and all the departments, and we did a lot of education. We had a form. We tried to hold each other accountable. We still used the form, and then when I left, they actually hired a person that worked full time on it for a year. That was just her job to get this going, and she did a great job. Her name was Fern.
That's a cool name.
Yeah, no, and the paper was green, because that's the national color for sepsis is green. But I always thought it was cute that her name was Fern.
Yeah.
They all match. So that was a good thing.
So what's the procedure when they come in and you guys suspect sepsis and you're trying to act within that 4-hour window? What medications are you giving? What procedures?
They'll give broad spectrum antibiotics, because they don't know what they have. So vancomycin, something like that, will be given, and then they'll usually fluid resuscitate the 30 milliliters per kilogram, if that patient can tolerate it.
Gotcha.
And get that going, and they usually draw the labs. So they want to do everything in like a 10-minute window. So we want to draw the labs, get the UA, take the patient to X-ray if needed, right? Triage very, very quickly, and then get that fluid and antibiotics hanging. And then that way, hopefully you can see a turnaround, and before you get an elevated lactic back.
Gotcha.
Because lactic's actually a latent sign.
Is it? Okay.
It's kind of like thinking about something fermenting on your table, right? Like it doesn't start fermenting and smelling pretty bad till it's late in the picture.
Yeah. Yeah.
If you just kind of think about it that way.
Is it? It's like a bad lactic lab it's over 2 or 4.
Over 2 would be high.
Okay.
Yeah.
So it's got to be
4
under
is
2.
like really bad.
Okay.
But over 2, you're high, and we should be doing things for you, even if you're not 2, because you might be in that window and we call you early. So that's why we do it. We repeat it.
Gotcha.
Yeah. So you'll learn all that when you go to the hospital about I got the repeat lab, and that's a priority to make sure you look for it at the exact time, especially when you're on nights. You got the patient came down at 7 p.m., right? They're fresh. You get them settled, and then now it's 11, and you're like, oh, I just sitting down. I'm gonna have a break, and then that's when you should be checking the lab because it's the repeat. Yeah, those are all the good things you're gonna learn.
It's
But you got fancy watches now, fancy phones
for reminders and timers and stuff. Okay.
I used to use the pump.
Oh, really? How would that work?
I would program the patient's fluid to only have 4 hours worth of fluid, and then it would beep at 4 hours, and then that was my alarm clock
for that specific patient.
Yeah.
Oh, that's a really good idea.
Yeah,
that's a really good idea.
That's what I did. I was like, oh yeah, Mr. Smith needed me to check what am I supposed to be doing? Oh yeah, I'm supposed to.
That makes that's honestly smart because it forces you to go into that room, assuming nobody restarted it.
Right. Hopefully nobody helps you out. At nights it's less people helping out.
Yeah.
I mean, it quiets down a little bit. But.
Isn't it gnarly a hospitalist job? How many patients are seeing?
Oh.
There needs to be double the amount of hospitalists.
I know.
Right?
I feel sorry for them. They really in their
call. Do they like being there?
Honestly, I bet. Can you imagine?
Are they making bank? You think?
I don't know.
Really,
I don't.
It
can't be that good for how much they work. They have the worst call schedule, and they work a week at a time.
And they're there. Over 12 hours. They sleep there, right? Or no?
No, there is one at night that sleeps there.
Okay.
But not per se them.
And they get pissed if you wake them up?
I don't think so. We had a very nice physician that chose to do the night ones because he had little kids. He's a very nice man. And I think he's still the main one that does most of the nights.
Okay.
I think it's kind of his dig. And he was never, if this man's still there. His first letter A for his last name, but very nice man. Yeah. No, he'd be right there.
Yeah.
So it was kind of a blessing.
Yeah.
That he wanted to do that.
I was doing a little bit of some student interning this summer, and then I remember forgot what the situation was. Oh, I remember what it was. Someone was having some issues, and for me personally, I was like, "Oh shit! That looks dangerous. We should probably call the doctor." And the person was like, "They only want you to call them if they're currently in a code, the patient." And so they just texted the doctor, and it all worked out. They responded pretty promptly, but that's an interesting concept that you have to kind of know who the hospitalists are and who wants to get a phone call, who wants to get a text message, who wants you to go knock on the office door. You know, I hope they're not too harsh to new employees.
I hope not too. There's a lot of you this coming.
Oh, there's
15?
23.
Well, but no, 15 on telly, right?
Oh, okay.
I think I counted 15.
Okay.
There's a
Someone
lot of
told me 23, but that might be for the hospital.
Yeah, 3 went to
ICU or ER or something.
3 went to ER, 1 went to OR, and 1 went to ICU that I know of.
Okay.
So it's 5. I didn't know you had 20. I thought you had 15. Maybe they're counting AG too.
It might be 23.
Oh, wow.
There's a lot of people.
Yeah. A lot of the class.
It'll be interesting to see who stays there long term, see who stays there for a year and goes to the next place and stuff. I'm living in this house, knock on wood, for a couple more years. So I definitely I plan to be there for a while.
Yeah, that's good.
Yeah.
Good to get 2 years. 2 years is cool.
Mm-hmm.
And then if you get kind of bored after a year and started school, that would be cool. Yeah.
Yeah,
after 6 months, you can use the payment reimbursement program.
Okay, and they'll just pay for your college.
So how it works is when you take college courses and you finish them, and you send it in, you just send it in that you completed and show them the grade, and then 24 hours later, not more than 24 hours, that money's in your bank.
Whoa.
I have never seen something more efficient in the hospital in my life.
That's crazy.
It's crazy.
That's crazy.
So if you finish the semester early, you turned in your grades, you get paid early.
Yeah.
It doesn't matter when it is. Like once you have the grades and you've showed you completed it, and yeah, it's like pretty cool.
Yeah. Yeah.
It's like really nice.
Are you excited to start the like the next coming school year?
Yeah, I think
or like
so.
did your summer go by too fast?
No, it's been really good.
Okay, that's good.
I've been doing a lot of work helping the accelerated program. So they did your whole semester in that you do in the fall in the summer. So they had 2 lectures for each class.
Say that again?
So they did it in such a short period of time that they had 2 lectures in each class.
So instead of 18 weeks, it's 9
instead
weeks.
of just chest tubes, she would do chest tubes and blood transfusions.
Gotcha.
In one day.
Whoa. So
and then you would go to, let's say, Darby's class. Instead of having 1 class, you had 2 of Darby's lectures.
Gotcha.
Right? Yeah. So every week they had 6 of your regular lectures. Or you would have had 3, right? Regular lectures. They had 6.
6 regular. Okay. So 6 lectures in 3 days.
Mm-hmm.
Okay. And this is to get a bachelor's.
No, it's to get
LV and RN.
LV and
gotcha,
RN.
because they do it in a year.
Mm-hmm.
Okay.
And then they did 2 clinical days.
Okay. So they're grinding.
They really were grinding.
Okay.
So
no summer break for them.
No.
Whoa. Honestly, at least they have medical experience.
Yes.
That must help.
I think it helped.
Yeah.
And they did good. This is their last week, and they have finals next week.
We're like, so you were helping out at summer school.
So I would go in once a week and set the lab up and tell her what we did for the week, and we kind of tried to remodify it. Yeah. Because it's so much information. Yeah. So we did a lot of that. But then it's set for now for the next time, for next summer, when the next group goes. Yeah. Right? So I thought that was good. That felt like good. I liked it. It was fun.
It almost seems like sometimes like there's a little like too much information overload to where you're just like, you learn it, you dump it, you get the new stuff, you learn it, you dump it, you get the new stuff. Like I kind of like it when it like you let it simmer for a little bit and you get, extra practice.
Have no simmer.
Oh man. That's just my brain. Yeah. Like I'm a very like slow approach. Like I need the extra time just to like absorb. But like I will tell you, once I have it, I have it. That's know what I mean? Yeah. Good. It just it takes a second for me to like grasp it. Mm-hmm. Like I had to like ask questions and stay after class and like learn it. Like knowledge is power. Yeah. For sure. Yeah. For sure.
So that's good. But yeah, that was my summer.
Just one day a week chilling.
Yeah, helping them with that and watching my grandkids. And
nice.
Doing fun things. Going to the beach with
Heck
them.
Yeah.
We had fun.
Nice.
Yeah, it was good.
Have you like been hanging out with any of the other instructors this summer?
Not the ones, the traditional ones, just the other ones. Not like Darby. I've only talked on the phone.
Do you think she would come on here?
Yeah, she might. Yeah, okay. She's a
I'll send
fun
her a
person.
text. I'll send her
she's
a text.
a fun person.
Yeah. She's nice.
Yeah,
she's nice.
She's good. She's done great.
Yeah.
She's a really good teacher. We had 100% pass this year.
Oh hell yeah! Yay! Hell yeah!
So that was good. The class did wonderful.
That's like, whew, it sucked graduating in mid-May and then just like not knowing when you're gonna take a test for like 6 weeks, and you're like, I was seriously studying like at least 6 to 8 hours a day, just like in here alone, and he would hit me up like, hey, we're going to the beach, we're going to the park, like, do you want to work tonight? Like, people would text me and I'm like, I can't do anything because I don't know when I'm going to take this, and I feel so underprepared. Yeah, it's like the more you do the practice tests,
the worse you felt.
Yeah, well, it's like fuck, like when when is there not going to be new information? Because I'm taking notes when I'm doing the practice test, you know, and it's like at some point I'm hoping some of these questions are like repeated a little bit, but it's just new stuff, you know.
All the time.
It's just new stuff. But what I will say is, in a bunch of the practice tests, they were asking about, and I feel like we didn't really learn this too much in school, but like Addison's disease, Cushing disease, like those are like steroid related issues, and then a bunch of muscular like nerve diseases, like multiple sclerosis and what's it called, like Guillain-Barré syndrome.
Right,
yeah, like I was like seeing it over and over again, and I kept getting them wrong, and I was like, I need to jump in the book. So like I pretty much made little bunch of flashcards for all that stuff, and then I just started getting everything right, and I was like, all right, this comes up on the NCLEX, I got it.
Yeah, because you just don't know what you're gonna get.
Yeah, it was a pretty hard test.
Yeah,
it was hard, and you're like, you know, you're in Santa Maria, like there's some other people in the room you don't really know. They they make you kind of like put everything in like a locker, and it's like, all right, like go do this 5-hour plus test or whatever, you know. But yeah, getting the results back and it's like you pass, it's like, whew,
that's off my plate.
Let's enjoy summer now.
Yeah.
You know? But then it was like July 4th already. It's like, whoa, wait, like stay in July for as long as possible, please. Like I want a little more, you know, time off.
Yeah.
It goes by fast. Life goes by fast.
It does.
For sure.
And you can't enjoy the moment if you're always stressing about school.
Yeah. Yeah. No, it's it'll be nice to not be in school.
Yeah.
For a little bit, you know.
Yeah. You need that.
Exactly.
You deserve it.
Thank you. Thank you.
Good job.
Thank you. I appreciate it.
Yeah, you did a lot of hard work.
I was I committed myself for 2 years, just like try and get the good grades, I guess, you know.
Yeah.
Yeah.
Good. That's good.
And I mean, it was fun. Like I enjoy like a good lecture, you know.
Well, and you guys all seem to make friends.
Yeah. That was cool.
That was nice.
Cool.
Yeah, you had new acquaintances. You have your new crew.
Yeah. And you did a pretty good job at making people laugh during your lectures because you're pretty like you'll like walk around and you'll get kind of like vocal and like you're doing stuff with your hands and stuff.
Yeah.
Like you'll stay
trying to keep everybody awake.
Yeah, for sure. Yeah. You'll say stuff sometimes. Like this one time, I remember I was in the back with Will. It was 4th semester, and then you were like, yeah, like you said this specifically. You said something about and then they go get their antibiotics at In-N-Out.
Yeah.
And we both looked at each other and were like, wait, what does that mean? Like, I have no idea what it... But we were laughing, you know? But, yeah.
Yep. They do. That's a med stop.
That's what you meant by that. Okay, gotcha. Is there anything you want to say before we end? Any closing statements?
No.
Or anything you wanted to talk about?
Just make sure you make it always about the patient. And even if you have a really bad day because the physician made you feel bad, the other nurses made you feel bad, or one of the patients made you feel bad, just remember the one good moment with that one good patient. Every day when I'd swipe out, I'd try to remember the one good thing so I could bring the good thing home. Swipe the rest of it at the box. Just remember that one good thing. There's always one good thing every day. And you'll have lots of great stories, which is lovely. I don't think there's another job that doesn't have more great stories. I know, because 2 of my kids are nurses. No, Mom, I got to be nurse because you always come home with a great story. How come it doesn't feel so great right now? I remember my son saying that. Doesn't always feel great, Mom. I'm like, yeah, you got to swipe that out. You just got to learn to process it.
Thank you.
Yeah.
Thank you. I appreciate you. Thank you. Honestly. Thank you.
Yeah.
Thank you.
Hey. Okay, we did it.
I hope that wasn't too bad.
No.
Okay,
I want to ask you one thing.
Yeah.